Great. I'm sort of losing my voice, so I blame my son. Hope it's one of the first of many things I'll blame on him in the future, probably. My name's AndrewSeaman. I'm faculty at OHSU and clinically based out of Old Town Clinic and the OHSU Impact Service. And my interest academically and clinically is the intersection of hepatitis C and substance use disorders, specifically or most importantly with people who inject drugs. And I'm going to really try to breeze through here. These are my disclaimers. I participated in an investigator-initiated grant, which I'll describe to you, or investigator-initiated study funded by Merck. It was underfunded, I would say, for my time. So objectives. Last year I talked about data and treatment for Hep C and people who inject drugs. I'm going to just focus on one study this year. Talk about both the results from our study as well as kind of our early data with our treatment program at Old Town Clinic, and then talk a little bit of where I think we should go from here. It's a huge screen. I'm not expecting you to see these numbers. The one study I really want to focus on is this is a response to a lot of the comments that we've had that we just don't have enough data in treating people who inject drugs. So this is I think the best response we've had so far. This comes out of a researcher in Australia where they do really wonderful work with Hep C. A meta-analysis of 3,634 patients of people who use drugs, mostly people who inject drugs, with a 90% overall SVR12 rate, and this is including studies, that dip back into the early days of the direct-acting antivirals, and so this is a very comparable number to what you would have seen in clinical trials, although a little lower, and I want to recognize that. But one of the big reasons for that, and this is the only other thing I'm going to mention about this, is that if you look at the bottom here, there's a really strong bias towards better outcomes, surprise, surprise, in patients in clinical trials, right? So the folks who were in clinical trials had much higher SVR12 rates, and this was very consistent with an odds ratio of about 2.2. And in this meta-analysis, only 25% of these patients were in clinical trials and the rest were in observational trials. So I think that strongly biased the results of the SVR12 results downward in this study. Either way, it's good enough. We all here in this room know we need to treat this population. I just wanted you to have this tool in case you get in a conversation with policymakers, et cetera, in the future. So very briefly, I wanted to relay the results, or the preliminary still in progress results of our study. We enrolled in a non-randomized fashion patients who were engaging with medication-assisted therapy in the Old Town Clinic setting, and people who were engaging in the outside-in needle exchange program. Our target enrollment was a pilot study, 25 in each arm, which was powered to detect a difference of 20% in treatment outcome, the primary outcome of SVR12. And then we had a sort of community standard arm at OHSU hepatology, and we actually added another matched cohort to look for this observational effect in, not matched cohort, another prospective cohort in the Old Town Clinic and outside in primary care clinics to kind of look for that clinical trial effect. So these are briefly our results. These are the columns you see up here are the opioid agonist therapy. That's what OAT stands for. So it's methadone or buprenorphine. And then the NSP is needle and syringe exchange program. And then the people who really should be people who use drugs, standard group, and then the community standard group. So the community standard was OHSU hepatology. The PWID group was Old Town Clinic and outside in. And then look at the first bar up there is the SVR12 intention to treat data. So again, almost always we care about intention to treat. I would argue this is one area where per protocol actually is really important. And the reason for that is that, so the intention to treat arm means everyone who's started is included regardless of how they do, or whether they drop out, et cetera. And then the outcome is a lab test, and that lab test is the SVR12 lab. So what you see is in our intention to treat arm, we had a 96% SVR12 rate in the opioid agonist therapy group, and then in the needle exchange group, looks kind of terrible, right? Around 60%. Now this is preliminary data. You can see the numbers there are small still because we have not fully we were almost fully enrolled, but that enrolled cohort has not fully gotten through the treatment collection date. But then you drop below to the SVR12 per protocol arm, and the numbers look much, much better. So we had 100% SVR12 in the people who made it to get their labs drawn. And so really this is primarily a deficit of the ability to follow through with getting labs more than it's a deficit of being able to treat these folks. So I think per protocol is actually really important in this group. And then you look in the our clinic-based groups did as well in both in the outside in and Old Town Clinic groups and the community standard groups. Only one treatment failure to date so far, and that's in the outside in group. So if there may be a real difference. It's a higher risk population, and we are going to need to see both treatment failures and reinfections if we're going to be treating a high enough risk population to eradicate Hep C. One quick thing I wanted to mention. So this is I highlighted the needle and syringe exchange enrollment figure, and I mostly just wanted to point out that box where there were 74 people who were excluded out of the 135 screened, and then 36 who were lost prior to completing screening. So some of this is artificial because we had our drug was Elbgras, which as you can see is sort of a dying animal. Not to point out any specific substances or any specific drugs, but it's harder. There's an NS5A resistance panel that's required, which is a lot of blood. It only treats genotype 1 and 4. And so that was a big barrier. We lost a lot of people due to genotypes, genotype 3 primarily. And then and we also had limited up. This is an artificial study, and then we limited it to low fibrosis patients because we were trying to get access to treatment for people who couldn't access it elsewhere. So not really a scientific question, really more of a social justice issue. And then 36 were lost prior to completing screening. Most of this was due to inability to get all the blood work. They'd come in, they'd draw their blood, they didn't get enough, their vein was tapped out, and they're traumatized, they never came back over and over and over again. So really needing to streamline treatment, needing to simplify, have as least amount of blood volume as possible, ideally finger stick based, which is something that hopefully we can talk about more next year, some projects we're working on. And, okay. So just really quickly, an update on the Old Town Clinic treatment program. So I want to, all the success I think you're going to see in the next couple of slides, I want to really attribute to Martina Mikowska, who's our Hep C program manager, and Lisa Nelson, who's our Hep C pharmacist. They have far more touches in the program than any of the providers do, and I really think it's on their work that has made us so successful. But basically we're a healthcare for the homeless facility. We have a lot of wraparound services, and we treat everyone for hepatitis C. We have a lot of people waiting to get treated who are low fibrosis. We started treating about 18 months ago, and we really don't, these are almost this 2 out of 3 last appointments thing. We've never really followed that. If you want to get treated, we treat you. So these are our early numbers. So this is on the left side. You'll see the patients who are referred. Those numbers are the referrals are consistently going up, and then the patients initiating treatment. The orange arm is our study arm. You can see we kind of enrolled fairly quickly in our arm at Old Town Clinic, and now that's fully enrolled. And then there's the program, and then that little yellow bar at the end is the patient assistance program, which thankfully we can put to rest, except for our folks who don't have insurance because they're undocumented. So great referral numbers, great treatment numbers, and then our SVR12, we have to date 1 treatment failure out of 111 people who have completed their treatment and completed their labs. We have and I should have mentioned this earlier, but there's this gap of about 20 people who did not get their labs done yet. There was a study out of southern Scotland, I believe, that looked at this group of folks. They were complicated socioeconomically, substance use disorders, etc. They were treated for Hep C, and then a bunch of them didn't show up. They aggressively went after them in the community to try to find them, and then compare the people who did show up for their SVR12 labs and the people who didn't show up for their SVR12 labs, and their SVR12 rates were identical. So the point is that, again, reinforcing that per protocol idea, not showing up for labs does not predict necessarily not being successfully treated for Hep C. So I would not use that as a bad surrogate. We want to get people in, especially if someone comes back and they're positive in the future and you want to know, is this reinfection, is this treatment failure, because it does change the regimen. But it should not be a reason not to treat this population. So really quickly, and I want to come back to that a little bit, but mention something that just to tack on to what Anne said in her great presentation earlier. The two things most associated with reduction in Hep C transmission are opioid agonist therapy engagement, which has been linked with a 50% reduction in Hep C transmission, and then needle and syringe exchange engagement with about a 20% reduction. And these seem to be additive. So as high as potentially an 80% reduction when you combine when geographic areas escalate both needle exchange services and opioid agonist services. So this is really important. I'm gonna come back to that slide. This is, I think, so a lot of these slides I've taken from INSTRU, which is a really wonderful international conference on Hep C and substance use disorders. And this is a modeling study done by Dr. Martin and Matt Hickman, who do a lot of the great Hep C modeling. And what you're looking at is the annual treatments per 100,000 people who inject drugs on the y-axis, and then on the x-axis, the baseline prevalence. Are these three different groups, 20, 40, and 60%. And I think last time I talked to Ann and Jude, we're probably somewhere around 40% maybe. We don't think we really know, but I would say we're probably in this range. And then what you're looking at, these four different columns are, what's the difference between no coverage for opioid agonist therapy and needle exchange services, all the way up to good, or 60%, opioid substitution therapy and needle exchange services. And basically, if we escalate these adjunctive therapies or harm reduction therapies and opioid treatment therapies, you more than halve the number of patients you have to treat in order to, in this slide, to reduce Hep C prevalence by 50%. If you're looking at elimination, it's even greater impact. And so, man, we are at a really wonderful window where we have a lot of money coming in through the opioid authority for the opioid epidemic, and then we have a lot of money we're spending for Hep C treatment now. Seems like we could save a ton of money and make a really good argument to payers that we should be covering needles. We probably have a way to fund increased needle exchange services, infrastructure, human resources, et cetera, but funding those needles has been really tricky, and it feels like the amount of money we're going to spend on Hep C treatment is a great excuse to fund needle exchange expansion, at least. And we already have a lot of good reasons to expand this, and I don't think of needle exchange as harm reduction as much as treatment for substance use. But great. We can come back to that, but I wanted to really briefly address the reinfection question, because this is what always comes up, and it's important to have something to talk about when people bring up reinfection. This is data from Jason Greebley, who does an amazing amount of work in Australia on this topic. Again, reinfection on the y-axis, on the x-axis is the year, and this is modeling, again, looking at, well, what if we treat 1% of people who inject drugs, or 2, or 4, or 8, or 10% per year, and then what will our reinfection rate be? What would our reinfection rate be modeled to be? And what this shows is that, if you're treating 10% of people who inject drugs per year, in order to reach that, you have to treat higher risk people and people who are using in a higher risk manner. And so what you'll see, of course, is you'll see a higher reinfection rate initially. But what you'll also see is that that reinfection rate is going to, once you start really getting treatment penetration, that reinfection rate is going to fall off because you're going to eradicate Hep C in this population. Whereas if you treat more conservatively and you treat, the population, you pat yourself on the back, maybe like us to a certain extent, where we have great treatment rates and probably very low reinfection. We're not there yet to give you that data. We're probably not going to have a super meaningful impact on the epidemic. And so you have to, don't treat the lowest barrier folks. Treat the highest risk folks. Get out there, start. The earlier you do it, the better. So we really need to get past this, start treating in these needle exchanges. I mean, HIV Alliance, amazing work. And, wow, can we treat there too? They're doing it in San Francisco. They're doing it in New York. We did it investigationally here. It's very possible. I'm happy to share and collaborate with anyone who wants to work on that kind of thing. So I'm going to stop there. Well, no, actually, I want to say a couple more things. I think, so this is where we are. Where we're going, in my primary interest now is the idea of microelimination and trying to extend microelimination outside of our clinic and into the central city concern sort of wilderness, including housing, substance use treatment programs, et cetera. And I think that housing, for me, I'm really interested in because we have a lot of it, and also people are kind of there. It's sort of like the much nicer version of treating people in corrections in that people live there. They don't have to live there, but they do live there and they want to live there. And so we're really looking at, in the next year, trying to figure out how to expand into treatment and housing, possibly by a mobile fiber scanner, possibly doing dried blood spot card-based screening, which is something I would love to talk to you all about if you are interested, trying to develop dried blood spot screening, which is a viral RNA-specific screening in probably LabCorp, but expanding to access to the state. So really interested in housing, really interested in screening and substance use programs. And then also going to be working with a group called Bridge HCV, which is based out of New Jersey, I think, but they started in Philly and then New York City and Baltimore, and then we will be their fourth site. And that's a capacity building endeavor to, for substance use treatment programs, educate on diagnosis and referral, and for people who are treating Hep C, mostly subspecialists, educating on this kind of work on treating people who inject drugs, and harm reduction as well. And so that's coming. If anyone's interested, mostly will be metro area this year, maybe rural next year. And then hopefully, the last thing I guess is hopefully Hep C Echo can maybe take on a little more of this next year. We're still looking into funding, but possibly moving towards this being more of a focus and elimination being more of a focus for Hep C Echo. And if you aren't aware of it, Lauren Myers in the back and Atif Saman have been doing really great work with Hep C Echo already. So I'm going to leave it off there and happy to take questions. Yeah.
Did you see the recent study treated 100 people who were actively using, and we're really interested in looking at compliance? Have you seen that study that?
So the question was, did I see the study at Baltimore looking at people who are actively injecting and looking at adherence? I didn't see that one, actually. I'd love to. There is the Simplified trial, which is a multinational trial that used Velsoft to treat people who inject drugs, had really great granular data using electronic blister packs. And so they have a lot. I've seen some pretty good discussions of that data, or those data, as well as another study in the Bronx that looked at with the same kind of blister pack monitoring that looked at adherence over time. The short of it is it drops off in the last 4 weeks. So with any hope, with GLECPIB being probably going to be 8 weeks for everyone, I don't know if everyone's heard that, but basically if you're non-decompensated, you're going to be cured with GLECPIB in 8 weeks. So I'm hoping that will solve that problem. But
what was interesting, 30 pills at a time. were compliant and so compliance up to days still had
Yeah.
still had
Yeah.
so out of 100, 84 reached cure. They had SPR or whatever.
Yeah.
But, yeah.
That's
So it was very good when you look at it that way because if you look at modeling, not only the harm reduction piece in the NATs, but if you can reduce the community viral load in the using community such that the prevalence is